Dear colleagues, thank you for inviting me to your conference. It's a great honor and pleasure for me to be here with you today. Today, I'm going to talk about regional anesthesia and cardiac surgery. My conflict of interest includes these companies, and this is plan of my talk. I'm going to briefly discuss recent eras programs in cardiac surgery, some challenges and pitfalls of regional anesthesia in cardiac surgery, central nerve blocks in cardiac surgery, facial plane blocks in cardiac surgery, and finally, we'll have some conclusions and take-home messages. First of all, let me start with the current era's cardiac surgery journey. As you can see, it doesn't differ very much from standard ERAS programs in other surgical specialties. When we want to take a closer look at pain management during cardiosurgery, we can see that, well, these guidelines are completely the same as in any other surgical specialty because they include multimodal opioid-reducing pain management in both operating room and in cardiac ICU. When we look at the recent guidelines published in JAMA Surgery just a couple of years back, we can see that there are no specific guidelines in terms of pain management after cardiac surgeries, because we can only see that a perioperative multimodal opioid-sparing pain management plan is required. When we want to take a closer look at ERAS programs in cardiothoracic surgery published a couple of years back, you can see that most of them are, well, not very precise because they can only tell us that opioid sparing is quite important, mostly because of the recent opioid epidemic in the United States, and that regional anesthesia can contribute to improve patient outcomes and a faster recovery process by providing effective pain relief while minimizing opioid use. So, when we take a closer look at a quite recent document on pain management and opioid stewardship in adult cardiac surgery, we can see that most of these papers again tell us that high-dose opioids are necessary and potentially harmful in cardiac surgery. This is quite important because even nowadays, many clinicians still believe that high opioid dosing is mandatory during cardiac surgery. These guidelines also tell us that perioperative opioid stewardship is a vital aspect of pain management, and we should use multimodal analgesia as a core tenet of perioperative care. So, multidisciplinary system-level interventions which optimize pain and opioid stewardship should be implemented. But then again, if we want to see some specific recommendations on the use of regional anesthesia techniques, well, we need to dive a little deeper. And we can see that the authors of these guidelines show us that in terms of perioperative pain management, we can use regional anesthesia techniques such as neuraxial, perivertebral, and facial nerve blocks. And we can also learn from this paper that all of these original anesthesia techniques, as part of a multimodal analgesia protocol, can not only help our patients deal with the perioperative pain, but they also have quite important drawbacks and side effects, which we should always keep in mind when trying to use these techniques in our patients. So, if you want to go into greater detail on discussing the role of regional techniques in recent cardiac surgery, we need to divide them into two groups: the so-called conventional techniques, which include perivertebral blocks and epidural blocks, and the new regional anesthesia techniques, such as, for instance, facial plane blocks. Let's start with the conventional ones. So many of you perhaps wonder why we discuss the role of epidural analgesia in cardiac surgery patients if we have robust data showing us that these techniques are actually quite efficient. We have good quality data coming from randomized controlled trials showing us on thousands of patients that epidurals are quite beneficial for cardiac surgery patients. And if we take a look at this quite recent meta-analysis with a systematic review, we can see that epidurals reduce ICU and hospital length of stay, they reduce postoperative complications, and are quite safe. So if we have a quite well-established regional anesthesia techniques, which most of us are quite proficient in using, why don't we just skip all the other techniques and use thoracic epidurals? Well, most of you perhaps know or anticipate, but this is not as easy as it seems. Most of us, anesthesists, and also cardiac surgeons are afraid of one potential side effect of thoracic epidural in cardiac surgery patients, which is, of course, the epidural hematoma. And if we take a look at this paper published in British Journal of Anesthesia almost 10 years ago, we can see that this is not a very typical or very prevalent side effect because there are only 9 epidural hematomas reported in cardiac surgery patients. So it seems that the number of patients needed to treat to save a life is 70 when it comes to epidurals in cardiac surgery, while the number treated to harm, which is usually epidural hematoma, is 1 to 3,552, which confirms the relative safety of epidural use in cardiac surgery. Nonetheless, most of scientific societies dealing with regional anesthesia will have one thing in common. They tell us to be extra cautious when delivering central blocks to anticoagulated patients. And let's face it, in cardiac surgery patients, most of them receive large doses of heparin. So we should always remember that central neuroctal procedures should be avoided in patients with no coagulopathy. We should always also remember that in case of a traumatic tap, we should delay the surgery by at least 24 hours, which is sometimes not very good news we have to deliver to our colleagues, the surgeons. We should also remember that the time from the neuraxial procedure to the systemic heparinization should exceed 1 hour, which also might be problematic. Heparinization and reversal should be monitored and controlled tightly. Well, we don't have problems with that. This is usually done even if neuraxial techniques are not employed. And finally, we need to remember that epidural catheter should be removed when normal coagulation is restored. So this shouldn't also be a problem. But most of us still are afraid of the potential very challenging scenario of producing an epidural hematoma in our patients. So this is maybe why we can find some papers which show us another approach. For example, this is one of my favorite papers showing that if you don't feel quite right about giving your patient an epidural, why not use a bilateral paravertebral block instead? This randomized controlled trial, published 6 years ago, shows us that this approach might be quite feasible. The pain control is almost identical when both groups are compared, But it seems that a bilateral paravertebral block might be more beneficial to our patients because they get discharged from ICU one day earlier and they have fewer side effects, including vomiting or urinary retention. But most of us don't think that replacing an epidural with bilateral paravertebral block is a good idea because, well, we have new players in town, is the so-called fascial plane chest wall blocks, which can be safely and efficiently implemented in cardiac surgery patients. I think that for the sake of this presentation, it should be wise if we divide these blocks into three major groups: the anterior chest wall blocks, the anterior lateral chest wall blocks, and finally the posterior chest wall blocks. Because, well, all these blocks can be used in cardiac surgery, but sometimes one may be more feasible than the other, depending on which kind of surgical approach is used during the cardiac surgery. The major problem with the fascial plane blocks in cardiac surgery is exactly the same as in other indications for these kind of blocks. Most of data comes from very small studies, sometimes cadaveric, sometimes these are just only case series or case reports. Well, most of them come from single centers, and we still don't know whether these types of blocks are actually feasible for our patients. So when we try to describe the difference between central nerve blocks or conventional ones, such as epidurals or paravertebral blocks, with the new ones, the fascial plane blocks, we need to remember that in most of the studies, well, the epidural analgesia was not compared with peripheral nerve blocks, because as you can see in this Cochrane review, there were only 4 studies comparing epidural analgesia versus peripheral nerve blocks in 2018. Most of these studies had a small number of participants, and, well, evidence was insufficient back then to show the effects of epidural analgesia compared with peripheral nerve blocks. And sadly, not very much has changed since then, because most of the studies on facial nerve blocks in cardiac surgery, well, they do not compare the gold standard, the epidural analgesia. They usually compare the patients receiving the regional anesthesia techniques with standard of care. Back in 2019, our team has published a study where we decided to compare the erector spinal plane block, the ESP, with standard of care in patients scheduled for mitral or tricuspid valve repair through a right mini thoracotomy. This was initially an observational cohort study. This was like 7 years ago, so this shouldn't be very surprising. And nevertheless, we have found that patients receiving ESP required significantly less oxycodone given via PCA pumps compared to patients receiving standard of care, so no regional block at all. And back then, this was one of the first studies in Poland dealing with the issue of fascial plane blocks in cardiac surgery patients. And this started a very successful ERAS program in one of our leading cardiosurgical centers located in Rzeszów in southeastern Poland. Another study in the same center showed that ESP was not only superior to standard of care in terms of decreasing acute postoperative pain, but it also showed that in patients receiving ESP, the prevalence of chronic pain was also significantly lower. So we have successfully demonstrated that ESP is not only very successful in decreasing acute postoperative pain, but also chronic postoperative pain, which is also very important in terms of patient comfort and satisfaction. So where are we now with the new regional blocks in cardiac surgery? Well, in 2020, the regional blocks, the facial plane blocks, were quite popular but only in few cardiosurgical procedures. In 2024, you can see that there are many facial plane blocks used for quite a large number of cardiosurgical procedures, even minor ones such as SICD implantation. When we take a look at these blocks, we can see that, well, as I said before, the type of block chosen for a specific surgery mainly depends on whether the surgical axis is via internal, lateral, or posterior part of the patient's chest wall. And it's always very important to remember that when you choose a facial plane block for your patient, you should remember what extent of the nerve blockade you want to acquire. In this part of my presentation, I would like to show you the simplest way to start implementing regional anesthesia technique in your cardiac surgery patients, namely the parasternal nerve blocks. This is one of my favorite techniques for beginners, and our junior residents are starting to learn regional anesthesia techniques in cardiosurgery with this type of blocks. There are mainly two types of parasternal nerve blocks: the superficial parasternal block and deep parasternal block. In our practice, we usually decide to use the superficial parasternal block, and it is sometimes called the pecto-intercostal facial block or superficial. We don't use the transversus thoracic plane block or the deep parasternal block, mainly because of the internal mammary artery, which can be inadvertently punctured during the procedure. In my opinion, the superficial parasternal block is just as effective as the deep one, and the safety profile is much better with the superficial one. So please go for the superficial one if you start your original anesthesia program in your cardiosurgical ward. Are these procedures safe? Well, it seems that parasternal nerve blocks or any other facial plane blocks are quite safe and efficient in cardiosurgical patients, but we always have to remember that potential complications are possible, and they usually include hemorrhagic complications with some degree of nerve damage. The good news is that in most patients, their neurological deficits are not fatal, and the patients usually completely recover within 12 months. And most complications in anticoagulated patients result from blood loss than from direct neurological damage. So when we go for deep plexus blocks, we should always remember that anticoagulated patients should be treated exactly as they were undergoing central regional anesthesia or neuraxial anesthesia, which means that we should be cautious, especially in patients receiving full anticoagulation. It's time for conclusions and take-home messages. It seems that knowledge and skills in regional anesthesia have become very important for anesthesiologists in today's era of minimally invasive surgery, and strive toward faster functional recovery and discharge. It means that if we want to limit the use of opioids in cardiosurgical patients, well, the easiest way to do that is to use to some extent regional anesthesia techniques. In my opinion, the epidurals are still gold standard, but if you do not feel comfortable or with this type of block in cardiac surgical patients, or you feel that the epidural hematoma is actually a very real threat, go for facial plain blocks. But we need to remember that physicians who are eager to offer new procedures, they usually have the patient's best interest in mind, and the efficacy and safety data of these blocks need to be constantly updated, because nowadays we still lack from good quality data, especially when it comes to comparing the central blocks or the classical blocks with the new ones, the facial plane blocks. With that, I would like to thank you for your attention, and once again, thank you for inviting me to the conference.